publication calls on the CDC to update stethoscope hygiene guidelines. This is because the CDC guidelines set the tone for infection control across the country. It has dedicated volumes on blatant hospital-acquired infection contributors such as hand hygiene, central line-associated bloodstream infections, and etc. Since the last CDC position on stethoscope hygiene, there's been a wave of consistent research that has contributed to our greater understanding of the stethoscope as a vector, and this should be reflected in guidance to healthcare professionals. For this reason, a working group of experts met and formed a consensus on critical issues regarding stethoscope contamination. The recent publication reviews the evidence and makes recommendations for stethoscope hygiene directly to the CDC. Alpesh, as one of the authors of the Infection Control and Hospital Epidemiology Journal publication, can you tell us why the group feels that stethoscope hygiene should be elevated to that of hand hygiene?
Well, if we really do believe that we need to do all this effort in improving hand hygiene because of transmission of pathogens and the hand serving as a vector, and as we discussed, the fingers really serving as a vector, then why bother with hand hygiene if you're not going to do the same thing with stethoscopes, right? Stethoscopes, we have shown, the wave of literature that you have shown, you described, has shown that the stethoscope is a vector of transmission of infections. The stethoscope is the third hand. The stethoscope, appropriately used and appropriately used in a way that prevents transmission of pathogens, achieves the triple aim in a big way. It calls to question, in other words, calls to action, the appropriateness of what we should be doing as healthcare workers and the healthcare system. And so this, I think, is a really important question at the end of the day, that if we are going to do something with the hands and hand washing, fair is fair, we need to do the same thing with the stethoscope. And I think the opportunity, as you said, is for the CDC to look at the literature, keep up to date with the literature, help enhance the literature through its guidance and studies, and then give the right guidance to the general healthcare system about how we can use stethoscope in the most hygienic way possible.
Very well said. Sanjeet, the data on contamination and transmission is clear with the stethoscope. Until we reflect this in guidelines, recommendations, and clinical practice, do you think we're leaving our patients exposed and our infection control policies incomplete?
Well, I would start by saying, or reiterating again, hands, the third hand as you described, and the transmission of pathogens. And anything we can do to minimize that chain of events is critical for patient safety, patient care, reduction in transmission. And yes, I'm saying guidelines often takes years to be updated, at times 10 years. 5 years is journal. And in today's time, data is being accumulated at a lightning speed. Things come in, and there's new developments, there's new technology. Just take example of COVID. How many drugs and technology just spurred by this event within a span of 10 to 12 months? It's astounding. And those things have been, and studies in relationship to these issues of stethoscope safety, transmission of bugs, is accumulating as you've published. So there's data that this is a vector. So I think it behooves on CDC and other bodies like Society of Healthcare Epidemiology of America to revisit how to better tackle this issue of stethoscope hygiene as well. And obviously, if you have a formalized guidelines coming from CDC, it carries a lot of weight to that. And I think doing the right thing is always the right thing.
Sarathi, as you were one of the authors in the call to action, you supported the idea that new innovations such as the Discover system be included in the recommended options to address the stethoscope hygiene. Why?
Great question. Everything that has been published from studies done on Discover, it shows that it works. And it's not just about this paper coming out as recommendations. I mean, this paper is actually coming out from, it's the culmination of studies that were done by multiple authors and multiple investigators in different institutions. And all these institutions, academic institutions, which have, IRB that looks at, is this study being methodically conducted, and has authors who are leading investigators in not just these particular studies, but publishing other papers also, who know how to conduct research and analyze that data very critically. All these studies have been conducted now and have been also published in leading journals. And based off of the data that came from these studies, these guidelines are now the final message that we're trying to deliver to CDC. And this is evidence-based medicine coming out as a culmination into one paper from a lot of us on this round table. And I think summarizing in Alpesh's words, I mean, Discover is a quality device. It reduces the cost, and it also improves the customer service. The perfect trio, the triad that we are looking for in giving to our patients. So I completely support that.
Thank you. Alan is a heart failure expert, somebody who teaches heart sounds to students. What are your comments on the disposable stethoscope that Dr. Kaura has named the deathoscope?
Sure. It's important. I think the CDC, in making decisions on new guidelines, needs lots of different inputs. And I think the more different groups among cardiologists would be, EP folks, but also heart failure people, to give inputs how important this is to have barriers and to not have to be stuck with a sick heart failure patient or a patient with shortness of breath. Often get put to the ICU, we don't know what they have. Since people are not putting those pulmonary artery catheters in nearly as often anymore in the ICU, we have to rely quite a bit on physical examinations. So the term deathoscope, I think, was really referred to these disposable stethoscopes that were really, you're taking away the cardiologist or anybody on the cardiology service or heart failure service the chance to come up with an appropriate diagnosis. And it's not how many you miss. It's not so much that the barriers are a lot cheaper than the disposable stethoscopes, but when you miss it in terms of cost that you ensue, sending a patient home, they come back 2 days later, much sicker in the ICU, they may need to be intubated. Talking about $100,000 extra by using the disposable scope than by using your own scope you're used to that you can put a barrier on.
Cindy, as one of the call to action authors, you were also the only person who had both clinical and administrative role in patient safety and quality. What are the critical takeaway issues to be considered here?
Well, I think they've pretty much been talked about in a variety of ways. Clearly, quality of care is first and foremost, and patient safety is all our jobs. What? First, do no harm. Here we are. In order to do that, we need to utilize the kind of technology that's available to us to do the best job possible. And at this point, especially after COVID, the CDC really, it's upon them to come out and give guidelines that need to be given to address the situation that we have here and now today. Maybe they got away with not having these really stringent guidelines in the past because there really wasn't necessarily the technology to meet up with that need. But we're in a different era now. People are looking at what we need to do and how we need to go about doing it. As a patient safety officer, I look to those guidelines to say, these are the things that I need to do, and to share with my healthcare administrators as these are the ways that we need to invest in different types of products, technologies, etc., in order to do the best job. It's pretty straightforward, the return on investment. One healthcare associated infection alone is way too costly, let alone one life. That's just not how we operate. That's not our game plan. So we really need to apply the stringent practices of best hygiene, hand hygiene, stethoscope hygiene, etc., like we would normally, and utilize the technology that makes it the easiest for the providers to do the right thing each time, every time, all the time. And whatever we can do to do that is going to work. And I think the CDC needs to lead the way, because they are kind of the guideline makers for all of us as providers to say, this is the right thing to do.
They are tremendously influential. Dr. Kipper, you're the only person here that has been using the Discover for the last year. Can you bring it home?
So yes, I've been using the system for over a year. First as a participant in one of the clinical trials, and now every day in my office I use it on my patients, and I'm happy to do so. It's quick, it's efficient, it works, my patients love it. There's a great deal of emphasis placed on the safety protocols that we utilize to ensure the lack of contamination we might throw at our patients when we use catheters, endoscopes, all of these other devices. But there's no such animal for our stethoscopes. I've thought about this for a long time. I'm happy that the people at this table have contributed to the creation of something that works. And I can tell you that as a symbol of safety and confidence, my stethoscope is, like we've talked about before, an extension of who I am in front of my patient. Having something that works and works every time and takes no time away from my patient is imperative. Having used the Discover system, it doesn't interfere with what I hear through my stethoscope, and it gives me the opportunity to actually listen more to my patient. So it's a twofer for me, and I just can't imagine ever going backwards, and hopefully I never will have to. It's also my understanding that the CDC guidelines haven't changed in over 10 years, and I'm not sure I've got this right, but I think the last set of guidelines encouraged us to clean our stethoscopes twice a week.
Or if they look dirty.
Or if they look dirty. Okay, so they added on if they look dirty. It's hard to see them looking dirty. I can't see COVID. I can't see COVID. I can't see C. diff spores. But clearly the CDC guidelines have to change, and here's an opportunity for them to do it without blinking. This should be a no-brainer.
They certainly have the data
They do.
to move forward. I'd like to thank all of our experts today for their perspectives on the issue of stethoscope contamination and its emergence as a significant vector. On behalf of Aseptoscope and the Discover system, I'd like to thank you for your recognition of the challenge with stethoscope hygiene, as it is this critical step that allows for its resolution. Thank you.